Good evening, all. I welcome you all to the Vijaya Diagnostic Center education webinar series. Today, we are going to present you with MR imaging in evaluation of shoulder instability. For this, we have two eminent guest speakers. Like one is Dr. Raghuveer Reddy. He is an arthroscopic surgeon specialized in knee and shoulder. Since he's practicing since almost 20 years in the field of knee and shoulder. Sir has done his MS Orthopaedics from Manipal Academy of Higher Education and fellowship in Manipal, Munich, Perth, Dallas, and Italy, and practicing especially shoulder and knee surgery in Hyderabad since 1999, and started his own hospital called Sai Institute of Sports Injury and Arthroscopy Center in 2005, and conducts a lot of workshops, and till now 13 courses were conducted, and he was organizing secretary for the 13th Indian Arthroscopic Annual Meeting conducted at Hyderabad in 2014, and trained more than 75 orthopedic fellows from India and neighboring countries. Welcome you, sir, for this webinar series. And with this, I'll invite Dr. Sarika. Sarika is a senior consultant radiologist working in Vijaya Diagnostic Center, and she is trained in eminent college, KEM Medical College, Mumbai, and she has special interest in MSK imaging. And she had a thesis on the shoulder topic when she was a resident, and she is very much interested in shoulder imaging since that time. He is now a consultant radiologist at Vijaya Diagnostic Center, Panjagutta branch, which is equipped with a very high-end 3 Tesla machine and 256 slice CT scanner, which is capable of doing cardiac imaging work. So with this introduction, I want to welcome Raghuveer Reddy sir to have some inputs, clinical inputs on shoulder instability, how you approach with your patients. Over to you, sir.
So you want me to first speak about what a orthopedic surgeon wants?
Yeah, right, sir. Yes. And what are the symptoms when the patient comes to you?
Yeah, that the symptoms the patient the history of regarding shoulder dislocation. But from surgeon perspective, so there I want to tell there are few surgeries. What we do is arthroscopic Bankart repair, and we do a remplissage. The patient is having Hill-Sachs fusion, and the patient is having a significant bone defects. Glenoid, then we go for lateral jet surgery, bone defects, bone stabilization surgeries. So we are interested in knowing this, whether he is fit for arthroscopic method or we are choosing an open method. Right. From that point of view, we can discuss further. I request Dr. Sarika to go further and present the talk.
You want to know the extent of tear also, sir? Like how much labrum, like whether only from E to C?
Yeah, if you are thinking in terms of Bankart lesion, from a surgeon perspective, if you want to do a arthroscopy, first thing surgeon wants to see is whether patient is having Hagel lesion or not.
Right.
If patient is a Hagel lesion, it is difficult to do arthroscopy. Okay, still we can do manage arthroscopy, but very few can done. So I want to rule out if you are doing a MRI in acute stage or initial dislocation, I want to rule out Hagel lesion. Right? And one is if patient is having a fresh dislocation, only patient will have a fusion. That will act like a contrast. So again, MRI is bony Bankart. If there is a bony Bankart is there, we can include in the arthroscopy method. Arthroscopy bony Bankart, we can do it. And the patient is an elderly patient, they can have a rotator cuff tears. So these are the things I want to look in MRI.
Any bone loss, sir? Percentage of bone loss you want to know?
Yeah, that if a patient is a chronic dislocator, then I request 3D CT. Nowadays, I ask more of course, we do see patient is having MRI scan, not only 1 or 2 scans, but I am interested more in CT scan, 3D CT scan, whether it is suitable for arthroscopic method or a open method. I am more interested in that. So CT scan also comes a major role in management of shoulder instability. I think even Sarika might speak few things about few slides about bony lesions with the CT scan also.
Thank you so much, sir. With these things, I welcome Dr. Sarika to deliver her talk on shoulder instability, role of MRI.
I hope my screen share is visible.
No, right now, no. Yeah, right now, yes, I'm able to see. You
Okay.
can put in a presentation mode, otherwise you can start, like if you're not able to do that. Yeah,
Okay.
I think, yeah, it's a
Thank you
little
so much.
smaller. Yeah, yes.
Slideshow.
The slideshow, uh, I think
Is
there is
it
a
visible?
problem. Yeah, it's visible. Yeah, you can start, I think.
Thank you so much, sir, for the introduction. Welcome, Dr. Raghuveer Reddy, sir, and thank you for taking time out from your busy schedule and honoring this session. I would also like to thank Dr. L.T. Kishore, sir, for giving the opportunity and his guidance, and to the entire Vijaya Diagnostic team for arranging this valuable educational platform where the various clinically and radiologically important topics can be discussed, and definitely it improvises the diagnostic accuracy and subsequent patient management. Now, coming to my topic of discussion today, that is the role of MR imaging in evaluation of shoulder instability. As we know, shoulder is a biomechanically complex, multi-axial, spheroidal type of joint formed by the articulation of the glenoid fossa of the scapula with the head of the humerus. It has got a widest range of mobility than any other joint in the body.
Slide is not moving.
Slide is not moving, sir. Is it?
It's in the first thing only, like your name. We are able to see your name.
Okay, sir.
I think you can move it from the scroll bar. Probably it will move.
Yeah, yes, sir. I'm doing the same.
Scroll bar?
Yes, sir. Is it moving?
No, no. Otherwise, click on the slide itself. I think it will move. I think second slide you can click probably. If you,
Sir, I'm not able to.
I'm not able to see it. Yeah, I'm not able to see.
Now,
Yes.
is it seen, sir?
Right now, I'm able to see. Yeah. Yes, I'm able to see now.
Okay, sir.
Right.
So,
You can
it is the highly mobile joint in the body, but at the cost of its vulnerability to injuries and subsequent development of instability. In fact, it accounts for more than 50% of the major joint dislocations presenting in emergency departments. So, it is definitely not a life-threatening disease, but certainly a lifestyle-threatening disorder which can effectively disable the activity of the otherwise active individual. So, instability is defined clinically as symptomatic humeral head displacement from bony glenoid and its abnormal sequelae. So, the patients with instability present to a clinician either with typical history of dislocation, or sometimes they present with only chronic pain or disability. So, this chronic pain and disability has got wide range of differential diagnosis like shoulder impingement with or without rotator cuff tears, or AC joint pathologies, or cervical disc disease. So MR is a valuable non-invasive modality of choice for evaluating these group of patients to assess the various pathologies resulting from recurrent dislocations. Anterior inferior instability accounts for majority of the cases, about 95%, whereas posterior, inferior, superior, and multidirectional accounts for remaining 5%. Now,
Sarika,
depend.
again, sorry to interrupt you.
Sir,
Your slides are not moving.
yes.
So you go to escape mode, it seems. You go to escape mode, and then I think it will move. You go to escape.
Yeah, yes, sir. Escape. Now,
Yeah, just try on. Right now moving, right? Yeah.
okay,
With
sir.
this mode, you only you present. So whichever slide you are right now, just yeah, that slide you can. Right.
Okay. Now, depending on the cause of the instability, again it is broadly divided into traumatic and atraumatic. In the trauma, the typical history would be fall on outstretched hand, or it can be seen in acute injury settings in athletes, such as in football or rugby players, or in repeated high load activities, or can be from chronic repetitive microtrauma. Atraumatic, it could be congenital, like dysplastic glenoid or lax labroligamentous structures, or could be acquired due to overstretching activities as in swimming and gymnastics. Now, Thomas and Matson's classification system is widely used by the clinician, and they have divided the instability depending on the directionality of the instability, mechanism of injury, and preferred method of treatment. In that, there are two main types. One is known as TUCS, that is traumatic unidirectional instability treated with Pankratz repair. Another is AMRI, that is atraumatic multidirectional instability, which is treated conservatively. Now, the most important structures which we need to evaluate when a patient with shoulder instability present for MR imaging are injuries to the labrum, the capsule, bones, any rotator cuff tears, neurovascular injuries, which are rare and can be seen in inferior pattern of dislocation, and the structures at risk include brachial plexus and the axillary vessels and nerve. So, accurate assessment of these entities is essential for planning for surgery. Now, briefly, I'll be discussing about the active and passive stabilizers of the glenohumeral joint. The active stabilizers are the rotator cuff muscles and the biceps muscle and periscapular muscles, whereas the passive stabilizers, the most important is the glenoid labrum, which is also known as the meniscus of the shoulder. It is a fibrocartilaginous ring attached all around the margins of the glenoid, and superiorly it is attached relatively freely, whereas inferiorly it is attached firmly. That's why we do see the labral variations commonly in the superior aspect of the labrum. The next important structure is the glenoid capsule and the glenohumeral ligaments. Glenohumeral ligaments are three in number: superior, middle, and the inferior glenohumeral ligament, of which the inferior glenohumeral ligament is the most important passive stabilizer of the glenohumeral joint. Now, these are the axial and coronal proton density pad suppressed images of the shoulder depicting the labrum. Sir, my cursor is not moving.
We are able to see.
Yes.
We are able to see that. Yeah.
I'm not able to use the pointers.
So the other pointer you can use right.
Yeah, now it's yes, sir. The anterior and posterior labrum are evaluated best on axial plane, whereas the superior and inferior labrum are best evaluated on coronal plane. So the labrum should be seen as a uniformly low signal intensity structure on all the pulse sequences. This is the sagittal image where we can assess the glenohumeral ligaments very well. So this is the superior glenohumeral ligament, which forms an important component of the rotator interval. This is the middle glenohumeral ligament, which can be seen further anteriorly, and this is the anterior and posterior band of the inferior glenohumeral ligament. Now, most important component of the imaging is the nomenclature of the glenoid labral tears. Now, there are various methods which are followed. The most commonly used method is the clockwise approach method, where the face of the clock is superimposed on the surface of the glenoid, and this is with respect to right and left shoulder, where classically the 12 o'clock is superior labrum, 6 o'clock is inferior labrum, and 9 and 3 o'clock with respect to right and left shoulder would vary. And also some MR units by default display the labrum from left shoulder perspective, even if the right is imaged. So as to avoid all this confusion, it is better to classify the labrum by this quadrant approach, which can be done on the sagittal image of the glenoid. A line is drawn passing through the center of the glenoid or the glenoid equator, and these two crossing lines would divide the labrum into 6 quadrants. So this would be the superior quadrant, antero-superior, antero-inferior, inferior, posterior-inferior, and posterior-superior quadrant. It is very essential to be mentioned in the report exactly in which quadrant the tear is located and the extent of the tear, because the surgeon has to plan the surgery accordingly, and depending on the extent of the tear, the cost of the surgery would also vary, because the number of suture anchors required to repair that labrum would vary. Normal labral variants, these are very commonly seen in routine MR imaging. So one needs to be very cautious while reporting this because they can be confused with tears. So the most commonly seen variants are sublabral rhesus or a sulcus, which is the frequent findings seen in 70 to 80%, sublabral foramen, buffered complex and labral bicipital sulcus. We'll be seeing the examples. So this is an example of a sublabral recess, which can be seen as a high signal intensity extending medially along the margin of the glenoid. Whereas the SLAP tear, it can be seen as a little irregularly marginated structure extending laterally along the humeral side, and it can extend beyond the biceps attachment. And another important sign is the single Oreo or double Oreo cookie sign, which is a highly specific sign for SLAP tears, can be seen in 20% of the cases of SLAP tears. So this is an MR arthrogram image depicting the double Oreo cookie sign, the two high signal intensities interposed in the substance of the superior labrum, giving this sign. This is a sublabral foramen, which can be seen in one or two sections, and it should not be confused with the tear. Another labral variant is the buffered complex. This is the thickened middle glenohumeral ligament and the absence of the anterosuperior labrum. So this constitutes a buffered complex. Another variant is the labral bicipital sulcus, which can be seen as a cleft between the under the surface of the biceps tendon and the superior labrum. So these variants should not be confused with the labral tears. There are three different scenarios for which the patient with instability present for MR. So the first would be the acute first time shoulder dislocation, but this constitutes a very less percentage of patients presenting to MR. The second would be chronic instability with repeated dislocation. Third will be chronic instability without repeated dislocation. So multidirectional instability, overuse injuries in athletes would comprise this group. The most important group is this. This we will be seeing. So MR imaging provides the valuable information to show the various osseous and soft tissue abnormalities that can guide the surgical planning and choice of stabilization procedure. Normally, the alignment of the joint is maintained because of the osseous congruity, synergistic muscle balance, and the capsulolabral integrity. Now, what happens in anterior dislocation? The most common, the humeral head is displaced anteriorly and inferiorly with respect to glenoid, so that the posterior superior aspect of the humeral head is hanged against the anterior inferior aspect of the glenoid, producing the classical lesions of the anterior instability. Whereas in posterior dislocation, exactly opposite will occur. Anteromedial aspect of the humeral head is hanged against the posterior inferior aspect of the glenoid. What are the various bone lesions which are seen associated with acute first time dislocation? Classic is the Hill-Sachs lesion, that is the compression fracture of the posterior superior aspect of the humerus. There could be avulsion fracture of the bony glenoid, the anteroinferior aspect, fracture of the coracoid process, fracture of the crater tuberosity, and fracture of lesser tuberosity. The most commonly seen labral region is the soft tissue Bankert lesion, also known as cartilaginous or fibrous, ankle lesion, Perkins and Alexa. This is the diagrammatic representation of various labral injuries which can be seen with anterior instability. The classical is the Bankert lesion, where the anteroinferior labrum is torn along with the torn periosteum. Osseous Bankert, along with the soft tissue Bankert, there is an osseous avulsion of the anterior bony glenoid. Reverse Bankert is exactly opposite of this Bankert lesion. Perkins lesion, this is actually a Bankert variant lesions. All these three are Bankert variant lesions, where the labrum is torn and the scapular periosteum is intact, which is minimally separated in Perkins lesion. Whereas in Alexa, the labrum is torn and displaced, and the periosteum is intact and it is widely separated. Glad lesion is along with the torn labrum, there is a destruction of the hyaline cartilage. Coming to these lesions, Bankert lesion is the most common labral injury following the first time dislocation. It is a pathoanatomic hallmark of the anterior instability that Bankert has described as the essential lesion in the dislocation. We will be seeing the examples of these. So this is the axial and sagittal protonicity pad suppressed images of the shoulder depicting the classical Hill-Sachs lesion. There is a compression fracture of the posterior superior aspect of the humeral head with significant marrow. One has to give the dimension of the Hill-Sachs lesion in this image, the transverse dimension in the axial plane and the depth in the depth also, and the superior inferior dimension. These three dimensions should be mentioned in the report. This is an example of a soft tissue Bankert, where we can see, because of the inherent fluid in the joint, the high signal intensity interposed between the torn labrum and the glenoid, and associated posterior labral tear. And this is the sagittal image depicting the osseous, there is no osseous abnormality. This is another example of a anterior labrum, and the sagittal image provides the valuable information with respect to extent of the tear. The antero-inferior quadrant, the tear can be seen. This is an example of an osseous pancart where we can see the labrum is torn along with the osseous avulsion of the antero-inferior glenoid. So size of this osseous fragment should also be mentioned in the report. This is another example of an anterior-inferior labral tear where we can see irregular high signal intensity in the substance of the anterior-inferior labrum and associated paralabral cysts. They are very commonly seen with the labral tears. Coming to Perthes lesion, it is a non-displaced Bankart lesion and the reported incidence is about 8%. It is a Bankart variant lesion where the labrum is torn but it is held in place by an intact periosteum which is minimally separated, and sometimes it can remain subtle on axial images, so it is important to obtain the images in abduction and external rotation manner to demonstrate that tear. And sometimes it can be spontaneously and the patient will not have any clinical findings despite the symptoms of instability, and it can remain undiagnosed even during arthroscopy. So imaging plays a very important role in diagnosis of this condition. So this is an example of an Perthes lesion where the labrum is torn. As we can see, a high signal intensity interposed in the torn labrum and the adjacent glenoid, and the periosteum is intact and it is minimally separated. This is an example of a Perthes lesion where on routine conventional axial images, the lesion is subtle, and on obtaining the images in this abduction and external rotation manner, we can see a clearly high signal intensity between the torn labrum. Clad lesion is nothing but a Bankart variant lesion along with the injury to the underlying articular cartilage, and it is usually a result of humeral head impaction against the glenoid rather than frank episode of the dislocation, and it is usually a stable lesion and commonly seen in athletes, and it is a rare injury, and sometimes with the chronicity intra-articular loose bodies can be found. So the treatment could be arthroscopic debridement of the labral and chondral defects. This is an example of a clad where we can see the labrum is torn and the disruption of the articular cartilage as can be seen as a high signal intensity fluid contrast is entering at the site of the defect. Hagel lesion is the important lesion to be diagnosed on imaging. So it can also result in glenohumeral instability. In the acute setting, it can be associated with significant periarticular edema and hemorrhage that can localize to axillary pouch, quadrilateral space, and proximal humerus. And specific sign has been described for describing this lesion, the J sign in right shoulder and reverse J sign in left shoulder, which is a fairly specific sign for IGL rupture. And on arthroscopy, it can remain undiagnosed, and so imaging plays a very important role in detecting these lesions. So this is a classical example of a Hagel lesion where we can see the labrum is the inferior tenohumeral ligament is torn from the humeral attachment site, and there is a significant periarticular soft tissue edema in the axillary region. And this is a J sign in right shoulder where we can see the retracted stump of the IGHL outlined by the fluid. Alpha lesion is a medialized Bankart lesion and is often the result of chronic injury, and its incidence is thought to be equal to that of the Bankart lesion even in first-time dislocations. So alpha lesion can heal in this displaced position. Sometimes in chronic alpha lesion, there is the proliferation of and deposition of the fibrous tissue on the displaced complex, resulting in scarring of the articular surface. And they are more complex lesions, have a worse prognosis than lesion, and they are associated with higher degree of bone loss with surgery. This is an example of a classical alpha lesion where the labrum is torn, detached, and displaced, but it is held in place by this intact periosteum, which is widely separated. Coming to second group of patients, which constitutes the most important group of patients presenting for imaging. So with first episode of dislocation, the patient would land up with repeated episodes with lesser degrees of force and provocation. And the role of imaging here shifts from lesion detection to their accurate assessment for surgical planning. And the primary goal of the surgical procedure would be the reconstruction of the humeral and glenoid osseous defects and repair of the soft tissues. So many of the same osseous and labral lesions can be seen, and the prevalence of the Hill-Sachs defect increases from 25% to 40 to 90% in repeat dislocations. Hemarthrosis, Hagel lesion, and other capsular injuries are more commonly seen in acute primary, whereas Bankard, Alpha, Hill-Sachs defect, and glenoid rim deficiency, greater tuberosity fractures are commonly seen with chronic repeated dislocations. Also, rotator cuff tears can be seen in both groups, frequent in recurrent dislocations. Glenoid rim can become flattened, deficient due to fracture or bony remodeling. So image interpretation should take into account exactly the size of the glenoid and the contour of the glenoid rim. So amount of glenoid bone loss guides the management. So for measuring the glenoid bone loss, 3D CT is the best, 100% the investigation of choice, and also for depicting the small osseous fragments. But with high field strength MR, I think MR is also equally good. So assessment of the glenoid bone loss can be done by various methods. The most commonly used method is the best fit circle method, where the circle is drawn on the sagittal image of the glenoid, which fits the inferior and posterior inferior aspect of the glenoid, and a line is drawn passing through the center of the glenoid, which is the axis of the glenoid. And this line will divide the circle into two equal quadrants, so that the accurate assessment of the bone loss can be made. This is the BRT image of the CT of the bony glenoid, depicting the normal intact pear-shaped glenoid in this case, where here there is a bone loss. So this bone loss divided by the diameter of the intact glenoid into 100 would give the percentage of glenoid bone loss. And if it is significant bone loss, say about 20 to 25%, then this procedure would be indicated, Latarjet procedure, in which the part of the coracoid is removed and it is attached here at the site of the defect with the help of the screws, and so as to maintain the machine's stability. Then assessment of the glenoid tract, whether it is on track or off track lesion, it is very essential. So what is glenoid tract? Glenoid tract is part of the glenoid in contact with the humerus in abduction and external rotation. So 83% of the intact glenoid minus the bone loss would give the glenoid tract injury. So 83% of this intact glenoid minus this bone loss is the glenoid tract. So the lesion is said to be on track or non-engaging lesion when the Hill-Sachs interval, that is the transverse dimensions of the Hill-Sachs defect, is lesser than the glenoid tract, then that lesion will not engage. That means only the repair towards the Bankard side would be enough. Whereas the lesion is said to be off track or engaging lesion when the Hill-Sachs interval is larger than the glenoid tract. That means only the Bankard repair won't be enough in such cases. Because of the large defect in the humeral head, the lesion is going to be engaged and the patient will still have a problem of repeated dislocation. So as to deal with this problem, the surgeon has to do a procedure known as remplissage, in which the part of the infraspinatus tendon is attached here at the level of the defect with the help of the suture anchors, and so that this concavity is filled and the lesion will not engage. These are the 3D CT BRT images obtained at our center, depicting the nice glenoid, the pear shape. So with this kind of images, I think the subtle small osseous fragments or exact accurate assessment of bony glenoid can be made accurately. Few slides about posterior instability. It accounts for 2 to 4% of the cases. Can be seen in violent muscle contractions as in seizures or electric shock. Classical lesions could be reverse Bankard and reverse Hill-Sachs lesion. So this is an example of a posterior dislocation where we can see a reverse Hill-Sachs lesion, a compression fracture of the anteromedial aspect of the humeral head and posterior inferior labral head. So this constitute the findings of posterior dislocation. SLAP lesions, they are also important and they can be associated with instability, about 20%. So they are originally described by Snyder et al. In 1990 as a lesion of superior labrum that extends from anterior to posterior. Most commonly it is because of the repeated repetitive traction to the biceps tendon, as in baseball pitchers or in throwing athletes. There are 4 main original types have been described, and additionally there are 6 more types. So the 4 types are: the slap 1 is the degeneration or fraying of the labrum. Slap 2 is the separation or torn tear of the superior labrum from the glenoid. Type 3 is the bucket handle tear. Type 4 is the bucket handle tear, but with extension of the tear into the long head of the biceps. This is slap 1, the degeneration of the superior labrum. This is slap 2, the separation type, the high signal intensity separating the labrum and extending laterally along the lateral side. This is the bucket handle tear of the labrum, superior, slap 3, and this is slap 4 with extension into the biceps tendon. 6 more types have been described. Just not got the example for the completion. Type 5 is anteroinferior pancart lesion in continuity with the slap 2 lesion. Type 6 is a combination of type 2 slap lesion with unstable labral flap, either anterior or posterior. Type 7 is the slap 2 lesion with extension into the middle glenohumeral ligament. Type 8 is type 2 lesion with posterior labral extension. Type 9 is complete detachment of the labrum from the glenoid. And type 10 is the superior labral tear with extension into the rotator interval with involvement of this superior glenohumeral ligament or coracohumeral ligament. Paralabral cysts, they are commonly seen with glenoid labral tears, and they are most frequently seen in the posterior-superior aspect. Anteroinferiorly, they are less commonly seen, and they may cause compression, neuropathy of the suprascapular or axillary nerves. So this is an example of a paralabral cyst in the superior-posterior aspect of the labrum, extending into the suprascapular notch with some denervation edema changes in the infraspinatus tendon. This is another example, anterior-superior paralabral cyst, and this is anterior-inferior paralabral cyst. So with regard to choice of MR imaging versus MR arthrography, the patient's presentation plays an important role. The patients with acute symptoms or severe pathological lesions, they are more likely to have intrinsic image contrast in the form of diffusion or soft tissue changes that allows the diagnosis and characterization without an invasive procedure, whereas the patients with chronic symptoms or pathological abnormality that is suspected to be more subtle on the basis of clinical assessment would more often require arthrography. So in conclusion, glenohumeral instability encompasses a broad spectrum of clinical complaints and presentation, and imaging findings depends on clinical scenario. And the imaging abnormalities that occur in acutely traumatized shoulder are substantially different from that of chronic unstable joint. So image interpretation and reporting need to emphasize the identification of lesion for diagnosis and their further assessment and differentiation for treatment plan. These are a few of the references which I used for this presentation. Thank you.
Thank you, Dr. Sarika, for an excellent, informative and lucid presentation. You covered most of the things related to instability and a lot of examples you have shown. And you have said about the bone loss, linear bone loss, and on track, off track also.
Yes.
I invite Dr. Raghuveer sir to comment on that.
Yeah, she has covered almost everything. There's nothing much to add. The only thing is significant bone defects. Previously, we were thinking it was only 20-25%. Now it has come down to 15%. So anything above 15%, we think as a significant bone loss. Then we go for bone stabilization surgery. If less than 15%, then we can do backward repair and plus and research. So from our point of view, it is only that we are writing this investigation only to know what type of technique is suitable for this. Especially as covered the research properly, and we are more. We want to know the data track. We want to see that the lesion is engaging or not. So we get nowadays some different places. We get only 3D CT scan, even without subtraction. So if you get good subtraction within the sagittal view of glenoid without humeral head, and give the percentage of the bone loss. How much is the percentage of bone loss, the glenoid defect? 10%, 15%, 25%, plus glenoid tract. So it will be easy for us to select the technique what to be used in patient. Of course, he has covered everything.
Regarding SLAP lesions, is there anything like any special information you need for SLAP lesions?
SLAP lesion is a lot of controversy is there because there is a SLAP is mostly is a arthroscopic diagnosis. Generally, what we do inside doesn't match MRI wise with arthroscopy. Most of it. And the loss of height was given to do the SLAP repair. Nowadays, we don't repair SLAP unless patient is very young, less than 30-35 years. Associated with the labral instability, we repair the SLAP. But if patient is above 35 and older, we don't do a SLAP repair. We treat the biceps somewhat distally. We go for biceps stenosis or biceps stenotomy. The patient is elder. And patient is younger, we go for tenodesis. And mostly biceps, we see the other features also associated rotator pathology.
When do you advise arthrogram versus the plain steady of shoulder is enough for you? When do you feel that just MR shoulder is enough?
Generally, if I feel that basically I want to rule out Hagel lesion. Otherwise, most of the patients, the arthroscopy factor, we do it. So, for surgeon, first thing is you want to know whether this patient is having instability, is having bone defect or not. Previously, we used to do a lot of arthroscopy backward defects without giving much importance to the indicator, without considering the bone defects. Study done by Jody Beer and Bukart, there is a lot of at least 25-30% failure of arthroscopy backward repair after 5 years. There is a having significant bone defects. Also, the concepts have changed. That's why you want to select the patient. Significant bone loss, we avoid the arthroscopic backward repair. But if you want to do backward repair, you do research. And significant bone loss, we go for other surgeries, targeted surgeries, or diagnostic bone graft, diagnostic bone graft, to treat the bone loss.
I want to know what like you expect from post-operative shoulder of instability to look for like in any patient who comes for any pain or again
Post-op is one more thing, a previous thing. If an MDA, multidirectional instability, we see the MR arthrogram with lack of spatulas. You can see the capsule tissue thing. The previous question was saying about MR arthrogram. So the patient is having MDA, we can do more spatulas and capsule. You can think about MDA also. And regarding the failure of surgery, then we can take contrast MRI. As I say, failed surgery. What do you mean failed surgeries?
Yeah.
Yeah, failed surgeries again. Most of the problem of failed surgeries is only not finding out the bony defect and treating that. And you want to see the loose anchors. What type of anchors they have used? Suppose now most of people they use only bioabsorbable. It's not visible in the MRI. But nowadays all suture anchors are coming. So still they are not seen in MRI. So we can see the halo part. So we want to see all these loose implants, the failed surgery, and bony defects, the failed stabilized failed cases. And infection.
Yeah, infection. Any infection Post-operative infection.
Yeah, post-op. But you see, yes, this also can be take the help of investigation MR.
Yeah. So we are not now presenting about rotator cuff, but that is on one more subject altogether. I think rotator
Yeah,
cuff
yeah.
thing, right?
But she has
So
covered everything.
we'll
Sarika
come
has
back
covered.
with the rotator cuff subject also in the next few months. I think I can believe my belief. So anything, Sarika, I want to say something extra.
Especially for SLAP lesions, the same doubt I have said for managing this type 5 to type 10 lesions. Are they valid, like clinically, are they important to be diagnosed on imaging?
Okay, not
So from our point of view, the SLAP, we don't give much importance nowadays. Anyway, and yes, as I said, it has been over-treated, just like over osteoarthritis, steroids used to treat OMBs.
Okay.
So previously, the SLAP players have been over-treated. And over-treated SLAP lesions, they go end up in stiffness.
Oh, actually, leads to more.
Yeah. That's why SLAP treatment is very selective.
You can easily, whether you can easily find out this before complex and sublabral recession on arthroscopy, is it easier or
Yeah, it is arthroscopy is 100% diagnosis.
100% diagnosis before complex and sublabral recession versus a tear, sublabral versus the slab tear, right? Okay, then I think it becomes easier. Like sometimes we get into some confusion whether it is a slab lesion or it's a sublabral recess on shoulder, MRI shoulder.
For anything labral lesions anterior to the biceps, we don't give much importance. Anything labral lesions posterior to the biceps incision, we give importance. We try to fix that later. So in labral lesions from 12 o'clock to 2 o'clock, we don't give much importance. Don't treat much.
Thank you, Dr. Raghuveer, sir. Thank you, Dr. Sarika, for an excellent presentation and excellent discussion about the topic. I think this would be really useful for the people who see this presentation. I think this will be uploaded onto the BDC website, and patients can have their the knowledge, and even the orthopedicians and radiologists, they can learn a lot from watching this presentation online. Thank you so much. Thank you for joining this discussion.
Thank you, Dr. Sarika. Thank you, Dr. Krishna, for
Thank you, sir.
invitation.
Thank you, sir.
Thank you, Dr. Krishna.